So welcome once again. We are delighted to have you join us for this final webinar for the Girl Generation Support to the Africa-led movement to end female genital mutilation, also popularly known as the TGG-ALM. So you might have encountered that in one way or the other. So thank you for being part of this special moment as we celebrate 5 years of learning, reflect on our journey, and share evidence and insights that will help us shape future efforts to end FGM. As a way of just giving the background, the TGG or the Girl Generation Phase 1, this is the Phase 2 that we'll be sharing. But just to give a background is we had a Phase 1 between 2014 and 2018. And this focused on united and amplifying the global movement to end FGM across 10 high prevalence countries through strategic communication, advocacy, and movement building. This Phase 2, which took place between 2021 and 2026, focused on generating evidence on what works and what doesn't work to prevent and respond to FGM. The program placed girls, survivors, activists, and community-led organizations at the center of programming while strengthening local leadership and sustainable approach to end FGM. Throughout Phase 2, as most of you are aware and have been part of this journey, the Girl Generation invested in 5 interconnected pillars: small grants, community engagement, integration of FGM prevention and response across sectors, strategic communication, advocacy, and movement building, which was famously referred to during the program as CAM, and evidence learning, knowledge generation, and sharing. Led by the options team, TGG-ALM was implemented by consortium including ActionAid, AMREF Health Africa, ORCID Project, the Africa Coordinating Center on the Abandonment of FGM, also known as ACAF. The FGM Data Hub, led by Population Councils, has ably supported the TGG-ALM on evidence and learning. Today's webinar provides us with an opportunity to share results from these programs and line evaluation, reflect on some of the key lessons, and share practical recommendations that can continue to inform programming, policy, and advocacy beyond the life of the TGG-ALM program. As a reminder to all of us, as we engage on this discussion and share our thoughts, I request welcomers to be mindful of the sensitive nature of FGM and all forms of GBV and the impacts, especially on survivors. I therefore encourage that we have an open dialogue, have an understanding, empathy, and create support to all survivors. Just another reminder, again, is that this webinar is interpreted in French, Amharic, and sign language. Please click the globe sign below the screen to select either French, Amharic, or sign language, and our interpreters will be on video all through the webinar. We'll also be taking questions and comments at intervals of this webinar, but also please feel free to type them on the chat box and we'll ensure to capture them. My name is Jacob Okumu, Advocacy Officer for the Girl Generation, and our moderator for this session will be Chichi, the Technical Director and Senior Associate at Population Council. Great. To get us started, please allow me to invite Dr. Jacinta Muteshi, the team lead for the Girl Generation, to give her opening remark. Over to you and welcome, Jacinta.
Thank you very much, Jacob. So good morning, good afternoon, and good evening to everyone joining us from around the world. We're delighted to have you with us today, and we appreciate you taking the time to join us across different time zones. Welcome to our final webinar for the Girl Generation Phase 2, implemented from July 2021 and ending July 2026. This is a real milestone for the consortium that implemented the program. It's the culmination of over 5 years of work supporting communities and activists in their efforts to end FGM and generating learning and evidence as we go. The data for this evaluation has been collected and analyzed by two leading research
Tout le
institutions
monde les
who've been
observé.
tremendous partners. Population Council has been part of the program from the start, developing new research tools to measure attitudes towards and incidence of FGM, and supporting options in our partners, including ActionAid and MREF, to strengthen our monitoring and evaluation. They conducted studies in Somaliland and in Narok and Isiolo in Kenya, which have generated valuable learning about what works to end FGM. APHRC have been working with us for several years now. Firstly, during our proof of concept assessments, which reviewed our interventions midway through the program to see whether we were on track and what needed strengthening. They led the endline evaluation, collecting data across Kenya, Ethiopia, and Senegal, and pulling together findings and learnings from across the whole program. We're deeply grateful for both their technical support, thought partnership, and commitment to delivering these studies under a challenging timeline. Thank you. I can't wait to hear you speak about your findings shortly. This webinar serves as a reminder that there is no need for anyone designing a program, project, or policy to end FGM to start from square one. Anyone involved in tackling this serious form of gender-based violence should take the time to review the existing evidence base to ensure that efforts are based on both local knowledge and expertise, and the wider body of evidence that has been generated over several decades. We hope that the speakers you will hear from today and the resources that we will signpost you to will be a useful starting point as our program closes and hands over the baton to all of you. Thank you very much. Back to you, Jacob.
Thank you so much, Jacinta, and thank you for those inspiring remarks. I'm taking away so much, and most importantly is that the programming to end FGM must not start from scratch. There's a lot that we learned today that can inform this programming. Great. To get us into the conversation, allow me to invite Chichi to guide the discussion from here. Over to you, Chichi.
Thank you very much, Jacob. Thank you so much, Jacinta. And hello, everyone. Thanks again for joining us. I would like to start by saying that the Girl Generation endline evaluation that we're here to hear about, it provides an opportunity to reflect on the program's journey and impact. And as we all know, evaluations are essential because they help us do a number of things. First of all, they help us understand what worked. They help us understand what could be improved and why. They also generate the evidence needed to strengthen future programs. They inform policy and investment, and they ensure that lessons learned continue to benefit the wider movement to end FGM. And so the evaluation findings to be shared today are drawn from studies conducted by the Population Council, and here this refers to the Population Council Kenya in collaboration with the Population Council Inc., and by the African Population and Health Research Center, or APHRC. And we're going to be hearing from speakers from both organizations today. Our discussion, again, is going to focus on endline evaluation findings from specific countries. Those countries are Kenya, Ethiopia, Senegal, and Somaliland. So to get us started off, I would like to invite Dr. Dennis Matanda, a research associate from the Population Council Kenya. Dennis will focus on findings from two countries, so Kenya and Somaliland. And within Kenya, the findings focus on Narok and Isiolo countries. You're welcome, Dennis. Please take the floor.
Thank you, Chichi. Let me just share my screen. Yeah, I hope it's in presentation mode. Thank you very much, and A big hello to everyone, and thank you for joining. So I'll take you through the endline evaluation findings that were conducted here in Kenya, that is in Narok and Isiolo, and also some of the findings that from data collected in Somaliland. So as maybe most of you are aware, there were a number of interventions that were implemented across these two countries. And I think the entire countries that I think Chichi mentioned where the TGG-ALM implemented. So there were organizations that took lead in implementing these interventions. That is the Action Aid International in Kenya here, who are implementing in Isiolo and also in Somaliland. And then we had AMREF Health Africa, who are implementing interventions in Narok. So across the two sites, there were a number of interventions, but for this evaluation, we concentrated on some of the key interventions, especially at community level. So as you can see on that screen, across the two sites, there is what they call community intergenerational dialogues, where you bring people of different age groups, gender, to be able to kind of like discuss and reflect on issues about FGM and generally other gender norms. That when then they can be able to see how they change their minds, their intentions, as we've seen some of the indicators that we measured. On top of that, they also had other layered interventions. For example, women reflection circles that were implemented in Isiolo by Action Aid, where given the understanding that in some of these communities, there's a lot of patriarchy and women need some sort of platform to be able to reflect on issues about FGM and just generally issues on gender. And then in Narok, AMREF also did implement an additional component that they first called couple dialogues. Later on, it was called homestead dialogues by the fact that in some of these communities, there's a lot of polygamous families. And therefore, if you say couple dialogues, you may lose out quite a number of other households that fall within the homestead. So our evaluation kind of like looked at community members who are kind of like exposed to some of these interventions, and those ones who are not exposed to these interventions that way. Then it is possible for us to say something about the effectiveness of some of these interventions. So our objective were to look at some of key indicators. One is on attitudes, how these interventions change people's attitudes in relation to FGM, some of the normative beliefs, behavioral intentions, as you see, and we also looked at gender equitable beliefs. But for this presentation, I think I'll focus on those three: the attitudes, normative beliefs, and then behavioral intentions. For some, for example, in Kenya and in Narok and Isiolo, we collected data twice, so we'll be able to kind of like see comparing two data points, but for Somaliland, it's only one data point where we collected data towards the end of the implementation. And this is just to summarize in terms of these were cross-sectional surveys that were conducted in specific areas where either Action Aid or AMREF implemented across the two counties, and our target was women of reproductive age between the ages of about 15 to 60, both women and men. And then those are the sample sizes, as you can see. So I'll go straight to the findings and what we have learned so far. The first one is, as we know, this is a social norm. Sometimes people's opposition to End FGM might not kind of also mirror what the other community kind of like think, other community members kind of like think, which is very important when you want to end the FGM, because sometimes as an individual you may want to end FGM, but what about your immediate family members? What about your extended family members, and so on, and the community as you go on what you call the socio-ecological level? So the findings here show, here for example in Isiolo, is that individually, you see that people, in terms of their support, is quite high. But if you ask them, well, your immediate family, do you think your immediate family will also support the opposition, kind of like decreases as you move outside the socio-ecological level. But the main message here that as you can see here, is that there was a difference between those who had been exposed to those community dialogues as compared to those who are not exposed. So as you can see individually, those exposed were higher. Their opposition to End FGM was high as compared to those who have not been exposed. And they were also more likely to think that their immediate family or extended family or community at large also had higher opposition as compared to those who are not exposed. It's the same kind of like picture if you look at also Narok, though as you can see, the support here in Narok, even at baseline, was quite high as compared to maybe if you look at Narok. But the trend is the same in terms of individual as you move up the socio-ecological level, but also in terms of those differences between those exposed and not exposed to the interventions and over time. Here in Somaliland, as you can also again see, because it is only one data point, there's a really clear difference between those who are exposed and those who have not been exposed, both at individual and at across the different kind of like levels. So this is very important in terms of, it tells us that the intervention kind of like had an effect in terms of those who have been exposed to oppose FGM, but also to think that people within their communities were also likely to support opposition, which is very important when you're talking about social norms. The second indicator was on attitudes. And basically here in terms of attitudes, we looked at support, especially when you're looking at certain factors that make people support. Look at a girl who has undergone FGM and a girl who has not undergone FGM. So issues to do with cleanliness, issues to do with being healthy, issues to do being equal to other girls, and so on. So we combine those indicators and as you can see from across the three kind of like sites, Isiolo, Narok, and Somaliland, the intervention in terms of those ones who had been exposed to the interventions were likely consistently to have kind of like reduced positive perceptions of FGM. But also in terms of a girl who has not undergone FGM, they tended to have more positive, be positive about the girl who has not undergone FGM, which is quite important again when you're looking at attitudes and what we think about a girl who has not undergone FGM, and that one was undergone FGM. The other area that we are also interested was in terms of behavioral intentions. And here we looked at two things. One, in relation to perceptions in terms of marriageability. We know FGM is quite related when you're talking about marriage. And also intentions to perform FGM. So across the three sites, what we saw from the data was that those ones who had been exposed to the interventions were likely not to intend to cut their daughter in future, but they were also likely to think that a girl who has not undergone FGM is likely to be married in the community. And there was a clear difference between those who are exposed and those ones who are not exposed. And being that marriage and sometimes intentions, these are very important when it comes to FGM. And if people think that their girls are not, for example, not going to be married, it has huge implications in terms of intentions even to cut. The other bit that we were also interested in is, given the programming and the different interventions that were implemented, is there any additional effect that you get when you implement these interventions, especially community dialogues, and then you add it with couple dialogues or homestead dialogues? So as you can see here, community dialogues on their own, they have an effect in terms of their influence. For example, here in Isiolo, you can see that those ones who have been exposed to the interventions were likely not to cut their daughters. they were also less likely to have kind of like favorable attitudes towards performing FGM. They were also likely to kind of less likely to think that a girl who has not been cut is marriageable, but also see they were more likely in terms of opposing FGM. In terms of the additional this layered kind of like interventions, as you can see in this on your far left, you see that is you are comparing those who have not really no kind of like intervention, and then when you implement women's cycles alone, and then when you implement community dialogues alone, and then when you combine both. But you see that here, when you combine these interventions, it has more kind of like impact. So as much as community dialogues are effective, but when you combine them with these other interventions, for example, the women reflection circles here in Isiolo, it has more impact, more benefits in terms of some of this, in terms of intention, either to cut, support for ending FGM, and also to think about marriageability of girls. Narok also, again, the same kind of like situation between those exposed and not exposed, and also in terms of the additive kind of like value when you combine also with couple dialogue. So you see that community dialogues are effective on their own, but when you combine them with couple dialogues, then they're even more, you get more benefits. Lastly, here in Somaliland, what you see here is we looked at those key indicators that the program kind of like wanted to change. So one of those indicators was favorable beliefs towards FGM, opposition and intention to cut, and marriageability. And what the data showed us is that in terms of those two indicators, one on having favorable beliefs towards FGM, there was that clear difference in terms of the intervention, those exposed and not exposed, and also in terms of intentions to cut data. So those exposed were likely to have higher opposition, and they were also likely to kind of like have positive beliefs in terms of ending FGM. But we see that it did not have significant effect in terms of intention to cut their daughters or perceived marriageability. So in other words, in Somaliland, they have not yet moved towards, people will oppose, people will have this favorable kind of like beliefs, maybe to a girl who has not undergone FGM, but in terms of intention to cut their daughters or for them to think about uncut girl being marriageable is still not very significant. So just quick takeaways, I think, from this presentation is that dialogue-based approaches are effective, but when you combine them with these other layered kind of like platforms, I think you get more value. Also, we see that the different, individually people may support ending FGM, but sometimes they are also constrained by the different other people who kind of like influence them, like immediate family or a community at large. And then we also see that there's need to expand some of these, especially, for example, in Somaliland, where change maybe is not yet at that level as compared maybe to Kenya. So thank you, and back to you, Chichi.
Thank you very much, Dennis. Those are fascinating results. I'm sure there'll be lots of questions and comments. I'd like to ask us to hold on to those. One of the things I take away from this, the one word, layering, the layering of interventions that actually work. I think that's important for us to hold on to. I think another fascinating aspect is really that tension between individuality and conformity or collectivity, right? Sometimes the individuality is really strong, but just not strong enough to come against what people perceive that the wider group thinks. So a lot for us to think about and take away from this. I am going to move us along to our next speaker. Our next speaker is Dr. Sumaila Uwedraogo. He is a postdoctoral fellow at the African Population and Health Research Center. And Sumaila's discussion is going to focus on findings from Senegal, Ethiopia, and Kenya. And within Kenya specifically, we're talking about Garissa County. You're welcome aboard, Sumaila.
Yes, thank you, Chichi, for allowing us to present those findings from the endline evaluation for Ethiopia, Kenya, and Somali and Senegal. Sorry. Yeah. So first, the evaluation objective was to assess the extent to which the TGG-ALM program has achieved its desired outputs and outcome based on the program result framework and capture lessons learned to inform future programming, right? And the evaluation scope and methodology is as follows. We have this repeated cross-sectional design with a baseline round survey, and then at the end line, we have also another round of survey intending to measure changes in knowledge, attitude, reported agency across focal hotspot. So the baseline and the end line both involve girls, boys, women, and men aged between 15 and 65 years. And if you have a look on the sample distribution at the end line, we were having like 560 respondents in Ethiopia, around the same in Kenya, and in Senegal, 2,268. Just because in Senegal we have four kind of counties, so grouped in two clusters. Okay, and to complement the quantitative finding, we carried out endline study with in-depth interviews in all the sites, key informant interviews also, and focus group discussions. Above all of those, we added an outcome harvesting, which we carried out in Kenya and Senegal, plus ethnographic study and participant observations. In terms of analytical approach, so we group the outcomes in two major groups: knowledge and social norms. In under this group, we have knowledge related to FGM. That's one outcome. Beliefs related to FGM, that's another outcome, plus gender inequality beliefs. So for all these three outcomes, they are made of several questions that we use to build a composite measure. Regarding the second group, intention and attitude, we have social sanction for FGM abandonment. This is also a set of 10 questions, plus attitude toward discrimination against and can't this. This other question outcome was a direct question from the survey. An opinion about FGM continuation and whether the respondent have ever encouraged anyone to abandon FGM or have intention to perform FGM on daughter are also two other outcomes, plus the agency to oppose FGM. So what we did is we built on those outcomes to build what we call an overall social attitude, which is a composition of social sanction for FGM abandonment, plus having ever encouraged anyone to abandon FGM, plus the intention to perform FGM on daughters. So these three set of questions, I just remember that the social sanction was 10 set of several questions. So we combine all of those built using multiple correspondence analysis, which is a statistical approach used in science, summarize, reduce data dimension, and summarize data. So these are the three group of outcome we'll be analyzing in the coming slides. Before moving ahead, there is something I need to notice. We intended at the beginning to make a baseline endline kind of study, but then we shifted to exposure-based analysis. Why? Because some respondents were already exposed before the baseline. Exposure occurred in both intervention and comparison areas. So it makes a bit difficult to determine who delivered activity and when exposure occurred. So that's why now we build a new variable called exposure category, trying to isolate those exposed within the intervention site. So respondent within intervention site who said they have been exposed to FGM-related activities, then respondent from non-intervention site, what we call control areas, who also said they have been exposed to FGM-related activities. And the third group were those who were never exposed to any FGM-related activity. For the analysis, we use a quantitative approach, descriptive statistic, bivariate, cross-tabulation, to see whether exposure and outcomes for each outcome, whether exposure is associated with or not. And then we use adjusted multivariate logistic regression models for each outcomes. Above that, we triangulate evidence from in-depth interview, focus group discussion, key informant interviews, and participant observation, and the outcome harvesting to support the quantitative finding, and then we run some contextualization and lived experience of participant to support the quantitative findings. So let's try to present a bit descriptives from those study. And as we can see for the end line, I'm focusing on the end line for the moment because these are the ones we run, even if we are not, we in the main report, we try to show that if we run, we pull the data, adding the end line, the baseline, it doesn't change the findings. But what we can see for the exposure currently is that the never exposed people, there are so many, they are dominating in all the sites, 72% in Ethiopia, 70% in Kenya, and 70% in Senegal. And most of the respondents in all the sites were women. For the age group, they were quite evenly distributed. Even if we have a slight dominance of older respondent, 45 years and plus in Ethiopia and Senegal. For the educational attainment, they are mostly with no formal education. Now, let's have a look on we're not going through the 2x2 association between exposure and all the outcomes for the sake of time, but what we're presenting here is adjusted odds ratio of the association between exposure and all the outcomes, but focusing on the exposure, while the model adjusts for sex, age group, marital status, educational level, and religion, ethnicity, and region for Senegal, because for the other regions, there were, all the people were from one single religion and one single ethnic group. So that's why we didn't account for those ones in the other sites. So what happened is that we can see that those exposed in intervention site were more likely to have high FGM-related knowledge in all the sites. They were also more likely to hold beliefs opposed to FGM in 3 over 4 of the site. In one of those sites, the finding, the association was there, but inverse. So this is like kind of unexpected. It's like exposure is making people like making them more opposed to FGM. And when we look at the gender inequality, it's not except in Amhara where we find an association. It wasn't the case for the 3 other sites. These are for knowledge and social norm outcomes. Now, related to intention and attitude outcome, when looking at the influence of exposition, we can see that those exposed in intervention site were more likely to being opposed to social sanction for FGM abandonment in Amhara and Garissa, but less likely in Kolda and Sédhiou for Senegal. They were less likely to be in favor of discrimination against uncut girls only in Garissa, okay, and less likely to be in favor of FGM continuation still only in Garissa, and in Garissa and Kolda and Sédhiou. When it comes to the other outcomes, having ever encouraged anyone to abandon, as we can see, exposure is positively associated with reporting to have ever encouraged someone to abandon FGM in all the sites. It's the same also for agency to oppose FGM. Regarding the intention to undergo FGM on daughters, this is less consistent compared to the 2 other outcomes. Now, looking at the overall social attitude, what comes clearly when looking at the exposure effects on the overall social attitude, we find that being exposed is positively associated with holding an overall attitude opposing FGM in Amhara and Garissa, but not in Senegal for both clusters. Okay, knowledge is less. There is no evidence of linkage or relationship between knowledge and overall social attitude, because we use the knowledge and social norm outcomes as explanatory variable to explain the social attitude. And there we find that knowledge really don't translate into changing the overall social attitude. But beliefs opposed to FGM is a strong driver of overall social attitude, as well as holding gender and equal beliefs. But the belief is more stronger because we find this relationship consistently in all the sites. For the gender unequal beliefs, it was in 3 over the 4. Okay, so based on this, our concluding remark are that exposure is a key driver of FGM-related knowledge in the 4 study site, and also a factor. A key factor in Amhara, Garissa, and the Kedugu region, not Kolda. Only in Amhara, exposure in intervention was associated with lower gender and equal beliefs. When it comes to intention, exposure is in intervention site always associated with higher likelihood to have ever encouraged FGM abandonment and to report agency to oppose FGM. But there were no consistent association across site for the other outcomes. So looking at the overall social attitude, what we can say is that exposure in intervention sites was associated with attitude opposed to FGM in Ethiopia and Kenya, but not in Senegal. But beliefs opposing FGM as well as gender inequality appear as key driver of change in the overall social attitude. So FGM-related knowledge have less influence on the overall social attitude. And all of those findings mean that exposure to FGM-related activities and FGM-related knowledge don't always translate into change in social attitude. Across all the sites, FGM-related beliefs, and somehow, we say somehow because as we have seen before, it's in 3 over the 5 sites. So FGM-related belief and somehow gender inequality appear as the major driver of change in social attitude. So these are the quantitative findings. Sorry. So we don't have time to present the quality findings supporting this, but from the main report, there are a lot of evidence from the qualitative findings that support this conclusion. So in the end, what lesson have we learned for future programming? The first one, as a recommendation, is the move beyond awareness to normal change. Pairing knowledge creation with deeper gender transformative dialogues is helpful and can help address power, control, social sanction, marriageability, and girls' bodily autonomy to address the root cause of FGM and explicit messaging to counter milder or medicalized FGM. The second one is the use of the right messengers for the right conversation. So it means we need to keep girls and survivors as catalysts while encouraging community-wide persuasion in locally legitimate champions with safeguarding and mentoring built in. The third one is related to the design for diffusion and reach. We mean by that there is a need to plan and resource repeated and sustained engagement that reaches those least likely to participate and track coverage as a measure of performance. Okay. The fourth recommendation is the institutionalization and resource system pathway. That means we need to deepen integration in health, education, and protection system, including pre-service training and supervision to sustain prevention, address medicalization, and ensure quality outreach. 5, and the last displayed here is about funding movement infrastructure for the long term, meaning that there is a need to provide multi-year flexible support for local organizations and coalitions, so gain do not erode at the end of grant cycles. So some of those recommendations are drawn from qualitative findings, and I can say that most of those we have a list of recommendation, like country-specific recommendation regarding each country or site findings, and then we have cross-country recommendation. But for the sake of time, we have to summarize and retain only these 5 key recommendations to share with you. Thanks, and up to TG.
Thank you very much, Sumaila. Another really brilliant presentation. And I guess for me, one of the things your presentation brings up is the fact that, we're not always operating we don't always get a quote unquote perfect research setting, right? Sometimes you get to the research setting and, the exposure levels of even the community that you hadn't planned to intervene in is high. What do you do then? So congratulations to APHRC for coming up with a method that could still allow for a rigorous evaluation. And if I had to take away one word that stood out for me, it would be, intentions. Intentions are still a sticky issue. And maybe we can get into that a little bit more as we move into our discussion now. So I'm going to jump right into that and start with Dennis. I really have the same question for each of you. It's really a two-part question, and I'm going to go ahead and just share those two parts. So Dennis, could you please share the most important recommendations that you have crafted as a result of this evaluation? And could you please share why each of these recommendations is so important?
Yeah, thanks, Chichi. I think to me, and you probably also hinted at it in terms of the key message that was coming out of these findings. I think the importance of layering these interventions is so key. And I think going forward, if we are thinking about ending FGM, we see that community dialogues on their own, they are effective, but they are even more effective if we also include it with other platforms. For example, we see that by just mere inclusion of kind of like women reflect cycles in Isiolo, or having these homestead dialogues in Narok, it gave an opportunity for inclusion of men in terms of community, homestead dialogues, but also the women-only reflection circles gave an opportunity to kind of like strengthen women's resolve and agency in terms of opposing FGM. So I think going forward, it would be very key that as we implement these community dialogues, which we really see a very good association in terms of intentions, in terms of some of these perceived kind of like social norms, that we also look at context in terms of some of these other layered interventions that can help. And then lastly, I think the issue about how do we kind of like reduce this gap between individual support that needs to translate across the different socio-ecological levels, because we all know that individuals may decide they want, as an individual may decide you want to end FGM, but other reference groups also have an impact. And I think it's important that we look at this kind of like other interventions that are going to also have impact on these other groups. For example, immediate family, more or less at community kind of like level, because it's a social norm. So it's very important that we do target those different kind of like levels, not just one in terms of like individual support. So that those would be like my two main recommendations and why they're important. Thank you.
Thank you very much, Dennis. I'm going to turn to you now, Sumaila, and pose the same question, which is, would you mind sharing the most important recommendations that you've crafted as a result of this intervention? And why is each recommendation so important?
Yeah, thank you, Chichi, for this question. Yeah, it's a bit hard to choose among those recommendations because, I mean, all of them hold each other like in a system. But what comes in my mind from what I presented is that there is a lot that have been done in terms of increasing knowledge, awareness, and all of those key aspects related to FGM. But still, these practices, like there is some resistance. And those resistance are mainly due to beliefs in those community. And as such, how to address those barriers could be, for me, the key. Addressing those social and cultural barriers could be the key to reach like very tangible result and change and translation from awareness and increased knowledge and whatever to a real change in attitude of within the community and at individual level. So I would say we need to think of what kind of intervention can be put in place to address those roots cause of the perpetration of this practice. So if something can be done of this, not in terms of community dialogue, because they have my community dialogue, sensitization activities, maybe there are some nice ideas that may come out in terms of addressing those cultural and social norms to transform effectively communities and individuals. Over.
Thank you very much, Sumaila. And thanks again, Dennis. Glad to see that we have some time left over for some Q&A. Jacob, at this point, I'd like to invite you back to take us through the next segment. I do see that there's an interesting comment already in the chat box. It's in French. I'm not sure who is going to translate that. I mean, I could translate it if nobody has it ready to cut and paste in English.
That would be helpful. That would be helpful, Chichi.
Okay, so the Sheikh Jiao is saying that it makes an important statement here that the social norms are stronger than knowledge. Even if even when a person knows that FGM is dangerous and constitutes a human rights violation, they'll continue to support it because they believe they're thinking about things such as rejection by the community, stigmatization of the daughter, difficulties in finding a marriage partner. Okay, somebody beat me to it. Thank you so much. Oh, thank you, Dimpy. Welcome. Thank you so much. Nice to see you here. Right. Yeah, so you can read there and see that, there is a lot of pressure, no matter what, the individual, no matter how much an individual might want to let go of this practice. So we need to figure that out. Yeah, how to make the individual beliefs a bit stronger. Thank you, and over to you, Jacob.
Thank you. Thank you so much, Chichi. Thank you, everyone, for that rich and engaging discussion. Thank you to our panelists, presenters, for the wonderful job and for the valuable insights that we've been able to learn from you. And if you're wondering where to get access to the evaluation finding and some of the even more of the learning resources, then I would invite you to our website. I'm going to paste it there. Mark, please confirm if that is working. So on the website, you'll be able to get this endline evaluation and even more resources that came from the program, which was learning on what work and what doesn't work in the efforts to end FGM. Yeah, there's a question here. What are some of the results that surprised you? And what insights are there on why we had some less positive results in some areas? So it's a question from Claire. Chichi, do you want to guide us on who we place this question to?
I think we can start with Dennis.
Okay.
Right?
Dennis, over to you.
Yeah, I think it's a very good question. And I think for me, context really matters. And I'll give an example of, I think, Somaliland. So this is a context where you're talking about 99%, 98 to 99% prevalence of FGM. And therefore, you might not really expect kind of like very big changes. But what we saw there is that I think when you're looking at attitudes and beliefs, there was a clear difference in terms of those who have been exposed and those who have not been exposed. So in other words, I think the intervention made headway in terms of influencing those. But still, there's still more work in terms of intentions, which is communities were more likely to tell you that they intend to cut their daughter, in as much as there's that kind of like influence. And also the issue of marriage in terms of marriageability. So that is still a big factor in Somaliland. So in terms of that continuum of change, these different contexts give you different kind of like findings, but it's very key in terms of programming people to be aware of situation they're working, so that then it informs some of the interventions or strategies in terms of who do they kind of like target in those communities. For example, in Somaliland, the issue of men involvement and how we can reach out is very key in terms of shifting some of those changes. So those are some of the maybe not, I don't want to call them negative kind of like findings, but I think findings that kind of like guide us in terms of programming or investment and how best we can be able to maybe get the change that we desire. Over.
Yeah, thanks for this question, Claire. I won't speak in terms of what surprised me, but in terms of unexpected kind of findings. There were these from the qualitative evidence we able to generate it. We find this kind of acceptance of medicalization of the practice, which is something in regard with the zero tolerance to any form of FGM is not like accepted. But still, I think it's kind of finding a kind of balance between, okay, how can we still continue, but maybe going into something that is perceived as less severe kind of form, but there is some work to be done in this regard. The other one is about how now people are shifting the practice from older children to more younger children. So the age at which the practice is done is now shifting to like a very early age as to like babies. So that they can hide they perform FGM on the data, and that's something also that they may need. We may need to think of something kind of approach to maybe track those kind of issues. The other one is not really a surprise, but it's difficult to manage. This is the cross-border kind of movement to perform FGM. But sometimes you may find in a country that they say, oh, people are going in the other border. But if you carry out a study on the other side, they will say people are coming, crossing and coming in this other border. So there is something to be done there. I mean, in terms of country collaboration between countries, so that to end those kind of cross-border movement to perpetrate the practice. That's my point. Thanks.
Thank you. Thank you so much. Thank you. Yeah, there are also a couple of comments here. We have one from Jen. Jen is saying that feedback about social norms being stronger than knowledge, that FGM needs to stop resonates with stakeholders' feedback across the various countries. Even those that would wish to cut, or rather, would wish to not cut their daughters are stuck because of fear of social sanctions, which have far-reaching implications on their daughters and family at large. Thank you so much, Jane, for that insight. Danish is also saying, what evidence demonstrates that survivor-centered approach has contributed to reducing the prevalence of FGM, and how can these approaches be scaled sustainably? So there's a question there of sustainability. So I want to read all the questions so that we tackle them together in the interest of time. So there's that one of sustainability. And also, thank you, Chichi, for passing this. There's, do you think the effectiveness of the intervention would be the same in setting where more extensive form of FGM, C type 3 are highly prevalent? What is your recommendation for communities where FGM is considered religious obligation? Do you think this intervention would be effective? Chichi, do you want to spread these questions also to the panelists?
I think in the interest of time, the panelists should go ahead and tackle, take a step, whichever one they feel, most fired up to address. Dennis, although I do see that one is addressed specifically to you, but I think with the others, please go ahead and sort of take a stab at whatever you'd like to do immediately, and then we'll see if there's anything left over that hasn't been touched on.
Great.
Yeah, I think I'll take this to the one on, do you think the effectiveness of the intervention will be the same in settings where more extensive forms of FGM type 3 are high prevalent, and the issue of religious obligation? I think FGM is just FGM, and to me, I think it has to do with maybe like the issue of prevalence. So in certain settings, for example, the way I explained in Somaliland, this is a setting where I think type 3 is very prevalent in fibrillation. And also you have the practice in itself is quite high. So 9 in 10 women have already been cut. And what we see is that context is very important, that in terms of the continuum of change, these communities might not be at the same level. So for example, if you're doing interventions in Somaliland and you're doing interventions in Kenya, or they are a little bit different kind of like settings. The dialogues may take a little bit longer in terms of the change that you want to see. In Kenya, I think you see quite progress in terms of those key indicators that we mentioned, but in Somaliland, you see that there's still more work that needs to be done in terms of looking at translating these beliefs or attitudes into behavior change in terms of either intentions or people believing in terms of the issue of marriage, that is acceptability of girls who have been cut or not been cut. The issue of religious obligation, I think this ties together with the finding that individuals may decide that they want to end FGM no matter what kind of like the individual they believe that they want to end in terms of like opposition, they oppose the practice. But we know that people don't live in isolation. So they live in a community. You have your immediate family, you have your religious leaders, you have your influential people, what you call a reference group. And it's very, very important that we address the issue of FGM, considering those different kind of like levels. So here, for example, you will need to include those religious leaders. That way, then you have some sort of mass kind of like information, but also coming from these influential people, for example, the imams and those quite powerful people in the community. That way, then, in as much as you are intervening at individual levels so that people support, but you're also giving them an opportunity for these other influential people in the community, either religious or traditional leaders or whoever is powerful. They are also kind of like also being converted and spreading the same message that it is not a religious obligation. And probably as a community, all of us kind of like think we need to end FGM, no matter the things that we attach on it in terms of ending the practice. So I'll stop there and then give maybe Sumaya also an opportunity to respond to those that he feels maybe he can.
Sumaila, sorry, just before
Yes.
Sumaila steps in, I just wanted to mention there are also a couple of questions in there that I think are well suited to some of our TGG-ALM folks who are on the intervention or advocacy side. If they would like to chime in, please feel free. But in the meantime, go ahead, Sumaila. Sorry, Jacob, you were about to say something? I interrupted you.
No, I just started to also just alert some on time.
Okay, thank you.
But please proceed. Please proceed.
Please go ahead, Sumaila, and then if there's time, maybe others can chime in from the audience. Thank you.
Okay. Yeah. Regarding the question of the effectiveness of the intervention, whether this would be the same in setting where more extensive form of FGM are highly prevalent, I wouldn't say I wouldn't expect the effectiveness to be the same, because as we cover different contexts, like in Kenya, Garissa, where they practice severe forms of FGM, but also in West Africa, in Senegal, we do have those kind of severe form of FGM undergoing there. But if you look at the findings, they are quite different. I think the big issue or the big kind of a factor that drive the effectiveness, how strong are the beliefs to FGM? How strong are those beliefs? Some of those beliefs may be traditional, some may, but in Senegal, above all, after running the intervention, being exposed, for some respondents being exposed to different kind of activities, FGM-related activities, people end up like being even more opposed, because they may perceive it, if they perceive it as something you are coming aware of what you said, but you are now coming with these two ideas from elsewhere. And from all the findings we presented, we have seen that in Kenya, beyond the fact that they practice these perceived severe forms, but they're the ones who show more positive findings compared to the other sites. I mean, Garissa compared to Amhara in Ethiopia, and the two other clusters of regions in Senegal. So I won't expect the effectiveness to be the same in setting where those extensive forms of FGM are prevalent. And if I have a recommendation for communities where FGM is considered as a religious obligation, I would say we need to stick on those voices that are highly listened within the communities only, because in those communities, they can clearly say, oh, this leader is not reliable anymore because he's getting money from, these NGOs or whatever, to now start turning his mouth from what was like considered as sunnah. So we may need to go beyond those community religion leaders, but to also have a kind of I don't know, is it if we can say international kind of bodies of religious leaders, where some scholars may raise voice, so that those community leaders at the community level don't be seen as like isolated. Okay, if there are other international renowned leaders, scholars speaking against FGM and raising voice, this can impact, and those community leaders can speak on them. I'm not the only one. Listen to X, Y, and Z, what they are saying against this practice, that this is not a religion duty. So this is something maybe we may also need to think of, not only speaking on those religious leaders, because sometimes they have a kind of voice and power, but it's limited. Over.
Thank you so much. Thank you. Great. So there are more questions. Dennis, the question that was directed to you, especially the findings suggest that dialogue-based approaches work well. Look ahead, how can this conversation be sustained within communities so that we shift social norms, continue even after the program? So I think that's a very crucial question. You might want to drop something on the chat box, just along those lines. There are also some responses on the chat. Please, I invite you to look through. And in the interest of time, we might want to pause there for today, but the learning continues. So I would like to invite you to look through the website, also go to the link that Mark has shared. Thank you, Mark, for sharing the endline evaluation for both the countries. Please read through them and continue to utilize this information to build stronger programs to end FGM. To close us out, allow me to again have the honor of inviting Dr. Jacinta to give his closing remark, thank you note, and officially close the webinar for us. It has been great moderating this alongside great Cheche, and thank you so much. Over to you, Jacinta.
Thank you very much, Jacob. And thank you, everyone. There's some really great reflections and questions in the chat box. And hopefully there's opportunity to explore these further so that we strengthen the work that we are doing. So before I begin my thank yous, let me first highlight the following. The Girl Generation website will remain active for the next 3 years to allow programmers, partners, survivors, donors, and champions to continue to access the global goods, the tools, and the evaluations that we have shared today. So please do take the opportunity to go to those sites. You may find some of answers to the questions you have asked today as well, and even just a strengthening of some of the reflections you've shared with us today. Now to my thank yous and appreciations. Our achievements as a program would not have been possible without the dedication, collaboration, and shared commitment of our consortium partners, team leads, colleagues, donors, government ministries, INGOs, survivors, champions, youth networks, civil society organizations, and many like-minded partners across Africa and beyond. Thank you to our donor, the UK Foreign Commonwealth and Development Office, FCDO, for your generous support through UK Aid and for trusting us to adapt as we learned. Your flexibility enabled us to respond to changing contexts, strengthen our approaches, and deliver greater impact where it mattered most. A special thank you to the Wallace Global Fund and FJSI for their continued support for our programmatic work. As consortium lead, Options Consultancy Services has been privileged to work alongside an exceptional group of partners, providing strategic coordination, technical leadership, and program management throughout this journey. The strength of this program has come from our shared vision, mutual trust, and collective commitment to learning and adapting throughout the program's implementation. I would like to express my sincere appreciation to our consortium partners, AMREF Health Africa, for their leadership and commitment to ending FGM in Kenya and Senegal, ActionAid for their impactful work across Kenya, Senegal, Somaliland, and Ethiopia, ARCAV, the Africa Coordinating Center for the Abandonment of FGM, for championing the integration of FGM prevention and response within health systems and engaging medical professions. Population Council's FGM Data Hub for strengthening the movement through evidence, data, and learning. Orchid Project for advancing our advocacy and leadership in global and regional spaces. The Africa Population and Health Research Center, APHRC, for leading our endline evaluation and helping us capture the evidence and let girl and woman can live free from FGM. This journey has been a collective one, and the progress we've made belongs to all of us. A very huge thank you. Back to you, Jacob.
Thank you so much. Thank you for that inspiring closing of this webinar. Thank you, everyone, the interpreters as well. Thank you so much. Thank you to our speakers for today and for Chichi for ably moderating these sessions. With that, I think Jacinta has closed us out. So see you and continue the great work. Thank you and bye-bye.